Guys, hello family, hello friends. This is Dr. T and welcome to Clinical Medicine with Dr. T. So guys, what I wanna do in this video, I just wanna give you tips on how to do well in anesthesia. So as you guys know that I studied in Pretoria University, but the tips that I'm gonna give you, I believe that they cut across. They're not specific to UP. So as much as I'm not aware how other varsities assess students when it comes to anesthesia, but I believe the tips I'm going to give you, they are sort of like standard. So they're sort of like standard. So guys, with anesthesia, remember my tips that I've shared with you before. With me, I've always preached one verse, and that verse is clinical medicine is all about going to the hospital, come back and study. Not stay and study and bang the hospital, stay and not attend, stay in your rest, stay at home, lock yourself in your room and study. That's not clinical medicine. Clinical medicine wants you to be there, to be involved. It requires you to be in the hospital and capitalize on those clinical hours. Those clinical hours, they are very, very important, guys. They are very, very, very important. And they're not important. Yes, they're important for you to pass, but it's more than that. They're important in shaping you to be a better intern tomorrow and a better medical officer tomorrow. When you go to hospital, it's like a car that has picked up a lot of mileage. The more you go to hospital, if you spend 2 hours today in the hospital, then you come tomorrow, you spend 4 hours. That day you spend 1 hour 30 minutes. Those hours, you can actually calculate them, count them, and that's like your mileage. For instance, the more hours you pick while you are a student is gonna help. That's gonna help you when you become an intern, because clinical medicine wants you to actually to be there to pick up the mileage, see what's done, get involved. That's clinical medicine. And if I use this example of a car, when you have picked up a certain mileage, there's no one who can take it away from you. It's like experience. When you've got experience, there's no one who can take your experience away from you. It's yours. You are gonna die with your experience. So, I mean, you cannot. I mean, a student that spends in a week that spends 10 hours in the hospital, there is no way that student will be better than a student who spends 12 hours or even 11 hours in the hospital. I mean, how can we be the same? Because I spend more time in the hospital than you do. Yes, you might know the theory in and out, but when it comes to practical and doing stuff, I'll be a better person. I'm not saying you must not study. It's easy to study when you have seen it being done. It sort of like stays in you. If you have seen, I mean, imagine they tell you about propofol, but you don't even know how propofol looks. They tell you about sevoflurane, you don't even know how it looks. It's gonna be hard for you to understand. It's gonna be hard for you to understand. So anesthesia is about being there, see it. That's what clinical medicine is about. So, guys, respect your clinical time. Try your best. If they say go to theater, spend time. And when you are in theater, there are times whereby the MO is gonna be very busy. They won't even teach you. But have this thing that try to develop an ability to learn when no one is even teaching you. And you can only do that when you're observant. I personally, I try to be observant as much as possible. I try to be observant as much as possible. And after being observant, even if you don't teach me anything, most of the times I'm gonna go and check it up, and then I'm gonna confirm what I actually saw, if it's in line with literature and all of that. So what I'm trying to say is, if you go to theater and you find that the medical officer is too busy, or he or she's having a critical patient, they can't teach you, you can't say you're not going to go to theater because you are not taught. You can still learn by just being observant. You can learn by being observant and being inquisitive. You can learn a lot. So yeah, I think that's a tip on its own already. So guys, with anesthesia, so what I'm going to advise you to do is that watch my videos. I've got a lot of videos that I've uploaded on anesthesia already. So please watch those videos. And remember, my content is not there to replace any other source of information. It's not there to replace your books. It's not there to replace your articles that you read. It's not there to replace your lecturers or your lectures. It's just an extra source of information. So with anesthesia, like I said, go to theater. Yes, go to theater and try to be observant. Try to be very observant. The thing is with anesthesia, the sequence of events is very important in anesthesia. It's very, very important. If you're gonna give 10 drugs to a patient, you give them one after the other, and there's a sequence that you follow. You know, if you're gonna give 10 drugs, which drug is gonna be number one? After that, which drug are you gonna give? After the second drug, which drug are you gonna give? After the third, which drug are you gonna give? And you have to master that. You must know it. For instance, you don't want to start giving drug number 9 whereas you're supposed to give drug number 3, because it's going to be a chaos, and the patient will complicate and actually have problems. So in anesthesia, things are done. It's a sequence, and people who have done it, who have been in anesthesia for a very long time, they know that once I've done A, I do B, I do C, I do D. And when it comes to exams, that's the sequence that they want. They want you to understand the sequence of events. They want you to understand it. For instance, I'll give you an example. For instance, they will give you a case. They will say, we have a 3-year-old male patient who's going for a graft. We want your approach to this patient. As an anesthetist, how are you going to approach this patient? So right there, when they ask you that question, you must know that, oh, okay, I'm not going to jump in and start talking about intra-op management. Because if you start by talking about intra-op, that you're going to give this drug, you're going to do this, then by that time you have lost a lot of marks already, because the approach for a patient that's going for an operation is a pre-op. We start with pre-op assessment, which I spoke about yesterday. So you do the pre-op. So you will tell them that I'll first do the pre-op, and this is what I'm going to do in my pre-op. Now when it comes to intra-op, this is what I will do. Then post-op, this is what I will do for this patient. So there is no one who can fault you when you answer like that. But if the question is specific, they say, what is your approach to this patient in theater, intra-op, what are you going to do? Then it means now you don't have to you don't have to try and answer and start with pre-op, just get into intra-op. The minute the patient enters the door and you transfer the patient from the stretcher onto the table, what are you going to do? That's the intra-op now. And it doesn't start, we're going to talk about it. It doesn't start by giving drugs and giving drugs and giving drugs. It starts with an IV line. It's very important. In many patients, an IV line is supposed to be done pre-op, but sometimes you find that the IV line is not working, you need to confirm that it's working. You need to confirm that the IV line, the cannula that is there, the caliber is the right size. Because sometimes you find a patient that is coming from the ward, they've got a blue gel core. It means now you have to change and put a green or a gray. Gray is the best option. So, and then now, if they ask you that you want to tell us about intra-op, then now you can start telling them about that. We're going to talk about that. So then now you get into what kind of anesthesia are you going to do. If it's general anesthesia, you'll put up. So we are going to talk about, I don't want to get into details about that now. So, and then now, if the question can also say, what is the post-op management of this patient? They will tell you, okay, this patient went for appendectomy, and then there were no complications intra-op. Now the patient has to go to now he has got to go either to the ward or to wherever. So now, how are you going to manage that patient? But if the patient say, for instance, if they say the patient intra-op had complications, had maybe abnormal pH, there was maybe metabolic acidosis, whatever, and then had hypotension, all those things. That means now, if they ask you what's the management of this patient post-op, the first thing that they're gonna say is this patient needs to go to ICU. That's the first thing. This patient needs to go to ICU. This patient must be managed in ICU. That's a point, because you are telling them that part of managing this patient, the best place to manage the patient is ICU, as opposed to a patient who are stable throughout the operation that can go to the ward. It's a mark already. And then what's going to happen in ICU? What's going to happen in the ward? What kind of medications are you going to give? Post-op medications? Are you analgesia? Are you going to give? Prevention of nausea and vomiting post-op, that kind of a thing. Pain management, antibiotics, that kind of a thing. So that's your post-op management. So what I'm trying to say here, guys, is that when they give you a question, they give you a scenario, and then they say, what's your approach? Try to understand, do they want me to answer from pre-op, or do they want intra-op answers, or do they want post-op? Establish that first. If it's a very vague statement, rather start with pre-op and say, okay, pre-op I will do this, intra-op I will do this, post-op I will do this. Not unless they are being specific. They say, what is the management of this patient post-op? What is the management of this patient intra-op? What are you going to do with patient pre-op? Ne? Yeah. So that's how you answer questions. So they will give you different scenarios, and it's important to read the question correctly. Look at the patients. Like, also another thing is that when you must know rapid sequence, you must know rapid sequence induction. They like to ask it. It's because it's very important. Rapid sequence. You must understand. I'm gonna do it. I'm gonna upload it. I'm gonna do a video on it. But you need to know about it. And the rapid sequence, you must know the sequence of events there. You must know what you do, what drugs comes after which drug, and all of that. And you must understand why we are gonna do it. You must understand why you have to apply high blood pressure. Also, with just a normal GA, when you are giving a GA, you must know the sequence of events. After you have after established your line, connected your monitors, pre-oxygenated, what's the first drug that you give? What's the second drug that you give? What's the third drug you give? When do you actually intubate? And all that, and all of that, and all of that, and all of that becomes very important. So know how drugs are given. Know the rapid sequence induction, and try to interpret scenarios to understand the question, and also to be able to. It's like when they say you've got most of the times when you've got a child who's going for operation, it's almost always a GA. It's almost always a GA. Even if they can say this child is going for amputation of the leg. Remember, an amputation in an adult, you might do a spinal. We actually do a spinal for them most of the times. But if now they want to confuse you and say that this patient There's another patient that is 6 years old, needs to go for an amputation. That patient is going to be a GA. The other one was a spinal cord, was an adult. Yeah, but they are both, the operation is the same. It's amputation for both of them. But the fact that this one is a child and this one is an adult, it changes the anesthesia. So that's very important. And also with children, one thing that you also must understand is that with children, when they come in, don't bother if they don't have an IV line. They are induced with SIVO. They are induced with SIVO. Children are induced with SIVO. They are induced. If you're going to do a GA on a child, you are going to induce them with SIVO. Yes, it has got those properties that it's a nice smelling gas. It's not irritant to the airway, or it has got minimal effect in terms of irritation and all of that. It doesn't have a pungent smell, all those things. So it's a nice gas, apparently, gas to inhale. So it doesn't irritate the kidneys. So with an adult who comes in for a GA, let's say you have decided that you're gonna give a GA. When an adult comes in for a GA, a line has got to be established before you do anything. Get that line before you do anything. But the difference is that with a pediatric population, when they come in, even if they don't have a line, you induce them with a gas, and when they are sleeping and unconscious, you start looking for a line. It's allowed, it's safe, it's nicer that way. So it prevents poking the child so many times while they are, and then just causes a lot of anxiety. And now you've got a child that's fighting you, doesn't even want to inhale your gas now because you've poked the child. So that's the difference. Ne? Those are the differences, and they like to ask the differences. So pay attention to the differences. And also, an elective sequence versus a rapid sequence, there's a difference. With an elective sequence, you must know which patients you will do an elective sequence, which patient is going to do a rapid sequence, and why you do a rapid sequence. For instance, in a rapid sequence, there's cricot pressure that needs to be done, but in an elective, it's not necessary to do it. And because these patients are usually fasted, these ones are usually unfasted, and you must know which patients are regarded as unfasted. And I mean, we are going to talk about it on our video, and then I'm going to upload. But an unfasted patient is someone who has had food, who has eaten, someone who has not been fasted, someone who's diabetic, someone who's people who have got people who are pregnant, people who have got some diaphragmatic hernias. Those are regarded as unfasted patients. So they have a higher risk of aspirating. That's why you have to do the cricot pressure. We're going to talk about those things. So understand these differences. They're very, very important. Another thing, when you go to theater, make sure that, like I said, you must be observant. The colors. SIVO, there's this thing that they call color coding system. If you look at SIVO, SIVO is always yellow, and eyes of learning is always purple, line is blue. So it's important. It's important. You must know if they, on an exam, they show you a yellow or a purple cylinder without a name, then they ask you what are the contraindications of this gas, or what are the indications of this gas, or how is this gas used, or what are the complications of this gas. Then you have to know, because it's yellow, it's SIVO. You start talking about SIVO. So they like to trick and ask like that. Now I think you must pay attention to the cubes, the color of the cubes, the yellow, the black and white. You must know what each tube carries. They like to show those on the OSCE, on a computer screen. Then they ask you about it. And also you must understand, and also you must know that those cylinders. A cylinder that is black, what is it? A cylinder that is black but it's got white shoulders, what is inside there? They like to ask those questions. And what else? And also another big one, know how to calculate a weight for the you know that formula, how to calculate to estimate the weight of the child, and also to estimate the tube that needs to be used, and understand the difference between a cuffed and an uncuffed. Those are the things that used to catch us off guard difference between advantages of using a cuffed and an uncuffed tube, and when to use an uncuffed and a cuffed tube. So things like that, guys. I'm gonna leave it here with the tips. I don't know if I'm forgetting anything. If there's something that I think that I've left out, I'll just do this I'll just upload a video again as a part 2. But I hope that helps, and let's meet on another video. Thanks so much.